Hi, everybody. Welcome to today's installment of the Spark seminar series. I'm Sue Tappan. I'm a member of the Spark Data and Resource Center, the DRC. Please join me in welcoming Dr. John Osborn from the University of Minnesota Medical School. Dr. Osborn serves as the director of the Minnesota Consortium for Autonomic Neuromodulation, where he leads research at the intersection of neuroscience and biomedical engineering. Today, John will delve into interoception and provide an overview of the role of the afferent renal nerves in the regulation of renal function and development of pathophysiologies, both renal and non-renal. Spark connects the body and the brain with open resources that support research into systems physiology and neural control in the periphery, such as our computational platform OSpark and the annotated maps which are generated from SCAN, our knowledge base of the peripheral connectivity. Spark is a member of the AWS Open Data Sponsorship Program, which enables all public data sets to be stored and accessed without cost for users and contributors. Spark ensures interoperability across diverse contributions to advance basic science, clinical applications, and bioelectronic devices. The NIH's Common Fund, SPARC, which stands for Stimulating Peripheral Activity to Relieve Conditions, was designed to accelerate development of therapeutic devices that modulate electrical activity in nerves to improve organ function and identify neural targets for bioelectronic medicine. The program operated in two main phases. In the first phase, Spark researchers mapped the complex topology of nerves that send signals throughout our bodies and studied how nerve activity can be modified to mitigate the effects of some diseases. Today, John will be focusing on his lab's effort to understand the afferent innervation of the kidney. Data from this project is available now on the portal. Dr. Osborn is also leading a project in the second phase of the Spark program. While this isn't the topic of today's presentation, I'd like to mention Spark Phase 2, which built off the success of Phase 1 to focus on the structure and function of the human vagus nerve. The vagus nerve, as you may know, is the longest cranial nerve in the body, extending from the brainstem through the neck and chest to innervate organs throughout the thoracic and abdominal cavities. This makes it an attractive neuromodulatory target. Throughout both phases, the overarching goal was to understand how these nerves connect to the brain and spinal cord to the rest of the body to develop neuromodulation therapies that could treat various diseases by precisely controlling nerve activity to restore normal organ function. Through his work with Spark, Dr. Osborn is advancing our understanding of how neuromodulation technologies can be used to treat disorders of the autonomic nervous system. His research focuses on developing innovative therapeutic approaches that could transform treatment options for patients with conditions affecting heart rate, blood pressure, digestion, and other vital autonomic functions. Vagal nerve stimulation can modulate heart rate, reduce inflammation, and influence mood and cognitive function. Its accessibility in the neck region, like we heard from our previous speaker in the series, Dr. Von Macefield, combined with its extensive connections to multiple organ systems, makes it an attractive therapeutic target for conditions ranging from treatment-resistant depression and epilepsy to inflammatory bowel disease and rheumatoid arthritis. All data, models, protocols, and tools generated across all individual contributors and supported consortia, including these landmark vagus studies, will be made available on the Spark portal, alongside over 350 curated datasets, models, and simulations from multiple organs, species, and research groups. The Spark portal shares complex multimodal data, meeting NIH, HEAL, and journal standards for scientific data repositories. Speaking of journals, we are very excited to communicate that we have partnered with Autonomic Neuroscience Basic and Clinical. By integrating data deposition into the publishing process, we're advancing our missions to make research more transparent and impactful. If you're considering submitting to ANBC, we hope that you'll also consider submitting your dataset and protocols fairly to Sparc. We're here to support you with grant language for data sharing plans and offer services related to computational modeling and simulation that can be utilized to augment your own research, as well as support the incorporation of non-animal models in your research. You can scan that QR code for more information if you're interested. Before I turn it over to Dr. Osborn, I just want to alert you to the fact that we're building out the schedule for the next seminar series. If you're interested in presenting or would like to nominate someone, please take a moment to fill out the survey at the beginning of the Q&A session. So with that, I'd like to encourage you to submit your questions in the Q&A area of the Zoom controls. John mentioned to me that he's very keen to hear from all of you, so please don't be shy. And with that, I turn it over to you, John.
Thanks, Sue. Everybody can hear me okay?
Sure can.
Great. Thanks for the invitation to talk in this series. It's been really great, and I'm happy to share what we've been doing. The Reveal project Sue mentioned about VNS, I am involved with a huge team that's working on that all over the world, actually, and hopefully we can talk about that someday. But I'm going to talk about a different topic here, which some people don't know. The people on the Reveal team probably aren't aware of my other life as a researcher working on this topic. The original title I sent to you, Sue, was The Brain-Kidney Axis in Health and Disease. And I'm going to tip it the other way around and give it away a little bit. Really, what I'm going to talk a lot about is what are the signals from the kidney to the brain that are involved in physiology and pathophysiology. I'm also here representing, we have a division of autonomic neuroscience, or autonomic neuromodulation here in the Department of Surgery. 4 of us, myself, Chris Bannock, we just recruited from University of Arizona. We were fortunate to get him here. We all work on neuromodulation of the kidney in one way or another. You'll hear some of Chris's work here, but also he's working on polycystic kidney disease in this realm. Louise Evans is doing some really beautiful work on regulation of salt intake. I'll allude to that a little bit, just to give you an idea of what that's about. And then more recently, Alex Dayton, who's a practicing nephrologist, is in the group, and he's working on prophylactic renal denervation for tacrolimus toxicity that has to do with transplant patients. So I'm going to do some very general, quick intro slides here. Just I know everybody's on page on target with this, but just to get us off on the same track. Now, typically, when we talk about neuromodulation, we talk about deep brain stimulation, for example, for Parkinson's, spinal cord for pain and paralysis. And the whole Sparc program is really about going after these peripheral nerves, sometimes in a very organ-specific way, of the autonomic nervous system, right? So both the sympathetic and parasympathetic system. Now, when I lay this out and talk about this, I mean, the general idea, if we think about the heart to start off, all organs are receiving, for the most part, sympathetic green, parasympathetic input, but also sensory innervation back to the brain. And the sympathetic and parasympathetic are physiological antagonists for each other. And the heart's the easiest one to think about, obviously. If you increase sympathetic activity, you increase heart rate. If you increase parasympathetic activity, you decrease heart rate. But what I want to point out here, the sensory innervation of the heart is there for both normal physiology, for example, pressure in the heart, volume of the chambers, but also in pathology. So angina, for example, these pathways would be activated. Now, that's pretty much the setup for most every organ in the body. And so we talk about autonomic control and its critical role in homeostasis, and that you have a balanced input of both sympathetic and parasympathetic to these organs to maintain all of these functions, right? So a balance of those two is critical on a moment-to-moment basis. We all know now that there are a number of diseases that are related to a chronic activation of the sympathetic nervous system and low parasympathetic activity. And that imbalance over time leads to all kinds of problems. So I'm listing just a few of them here, or cardiovascular arrhythmias, hypertension, metabolic diabetes, inflammation, and so on. And we'll get into a few more a bit later. So this is really the problem we're dealing with. How do we modulate to get back to a normal balance. Sparc is stimulating peripheral activity to relieve conditions. So the condition that I've been working on for pretty much my whole career is high blood pressure. And hypertension is the leading cause of death and disability in the world. It has been for a long time. And this is showing you the age-adjusted death rates due to hypertension. And what you should note here is we're not doing very well at it. It's going actually higher and higher. This only goes out to 2015. But despite all the medication we have, despite the education we have, we're not doing a very good job of treating it. So that means either the current drugs aren't working or people don't take them, which oftentimes can be the case. There really are no new drugs in the pipeline at this point. So the idea is we need a therapy for high blood pressure that does not involve taking medication. That would be the goal. So what's happened in the last 10 years or more now is this idea of targeting the kidney to treat hypertension. And the idea of this is that the sympathetic nervous system innervates all organs, which could increase blood pressure. But hypertension, perhaps, and I'm saying perhaps, is specifically because of the nerves to the kidney are causing high blood pressure by altering kidney function. That's the basic concept. And we know that if you increase the nerve activity to the kidney, you cause all kinds of things that increase blood pressure. You activate the renin-angiotensin system. You cause sodium reabsorption. You constrict the vessels in the kidney. And there's a lot of data now, and I'll show a little bit, that you can cause renal inflammation. So very simply, the concept is let's interrupt those neural pathways to the kidney. Let's reverse all of those and treat high blood pressure. So that was based on animal studies a long time ago. And then more recently, in humans, this has been the approach. And there are 3 companies now that use a catheter-based targeting of the nerves in the kidney by going into the renal artery. This shows the Medtronic catheter, for example, by targeting in the vessel, ablating those nerves either with radiofrequency, Medtronics, or ultrasound as ReCor. Ablative Solutions injects alcohol out to those nerves to destroy them. Now, you should realize or know that 2 of these are now FDA approved. So this is a treatment that can be used for treating hypertension now in the United States. Just quickly, these are different clinical trials for all 3 catheters. And what I'm going to say is that if the procedures are done properly, you get pretty much a drop in blood pressure using all of the procedures in a way that is equivalent to maybe 1 anti-hypertensive medication. So it works regardless, I would say, regardless of the energy that you use or the approach that you use. Now, this is where we make the switch, though, and how it works. And that's what we put a lot of work into studying in preclinical studies, is in some of these patients, you denervate the kidney, and the idea was you're interrupting the nerves to the kidney, but you saw effects in other organs or targets that were not easily explained in the beginning. So for example, if you measure muscle sympathetic nerve activity, something Vaughn talked about in his talk in humans, so sympathetic activity to the leg, that goes down if you denervate the kidney. Many patients with hypertension have impaired glucose regulation. Some patients that improves after you denervate the kidney. Cardiac arrhythmias, AFib, things like that are common in hypertensives. Those seem to go away, and even sleep apnea seems to be reversed. So this starts to paint a little bit different picture about what's happening. And so the idea that we've been working on is people with hypertension, animals with hypertension, have inflammation in the kidney. And what we think is happening is that inflammation is driving the afferent or sensory nerves that are then going to drive pathways up to the brain and then sympathetic output to other organs that cause all of the other symptoms. So really, it's this sensory pathway that is the problem. So if that's true, then if we perform a targeted ablation or neuromodulation of the sensory nerves, that could be a treatment for hypertension. And that's the idea we've been working on for a while that I'll talk a bit. So this is a figure I'll show a bit through the talk from a review a few years ago now. The original concept was the brain-kidney axis is activated in hypertension, causing these problems. But we think this is where a lot of the action is. That is, you have inflammation in the kidney. is stimulating these sensory nerves from the kidney up to the brain, modulating these autonomic networks, and then influencing sympathetic activity to these different organs, resulting in different things. I'll talk a bit about this. We think that the cytokines that are present in the kidney with this inflammation may show up in the urine, so we're working on the idea of a biomarker to predict efficacy. This is a nice image. These are human renal nerves taken at different points along the renal artery, and I've color-coded my diagram over here. So what you see red in these bundles are sympathetic or TH positive sympathetic nerves in that bundle. Green are the sensory or the afferents. So you'll see a lot of red. You'll see some sensory. That's one thing. Maybe about 10% of the fibers are sensory. The rest are sympathetic. But the point I want to make here is these are all mixed in together in the nerve bundle. And what that means is with these catheter-based approaches that are being used in humans right now, it's impossible to selectively destroy afferent or efferent, so you're destroying all of them. So people that get a catheter-based procedure, you destroy afferent and efferent nerves to the kidney. So knowing that, we wanted to probe the idea or look at the role of the sensory nerves in the kidney. So Jason Foss, pictured here, I think this was at an American Heart Hypertension Council meeting, developed a chemical technique in rats to selectively destroy only the sensory nerves of the kidney and leave the sympathetic intact. So the sensory nerve is shown here in blue. The red would be the sympathetics. Basically, you open up the animal, you expose the vessels, and you soak with a piece of gauze the vessel and therefore the nerves with capsaicin solution. And capsaicin activates these TRPV1 channels that are in the sensory nerves in a way that it is massively activating calcium influx that results in cell death. Sympathetic nerves don't have these channels, so the sympathetic nerves are intact. You can go look up this paper to get more details, but this is just one image from the paper. This is showing a cross-section in a rat kidney. Here is showing CGRP, which is the marker for sensory nerves, shown in brown. Red is the marker for sympathetics, TH. This is a sham animal. Here's an animal that had been treated with the capsaicin, and what you see is there are sympathetic fibers here, but we don't see any staining for the sensory nerves. So based on this approach in imaging, and we did functional things as well, we showed that we can get rid of those sensory nerves from the kidney. So Chris came and did a postdoc in the lab at the time and picked up this technique to look at the role of these sensory nerves in hypertension. This was published, gosh, in 2016 now. And basically what Chris did was induce a model of hypertension, this DOCA salt model. DOCA is like aldosterone, a sodium retaining hormone. Measured blood pressure by telemetry, and you can see in rats with the telemeter blood pressure measurements, blood pressure goes up over 21 days, about 21 millimeters of mercury. Now shown in the box with the X here is total renal denervation is done before we induce hypertension. So this would be just like the catheter based. It destroys afferent and efferent nerves. And what you can see very clearly is you cut the hypertension in half. You don't prevent it, but you cut it in half. The important point of the slide, though, is this group, the box with the dot, is only sensory denervation with the capsaicin technique. And you can see it looks essentially identical to if you took out both sensory and sympathetic fibers. So we concluded from this that the blood pressure response, in other words, the anti-hypertensive response to denervating the kidney, is due to the elimination of the sensory nerves and not the sympathetic nerves, which was the novel finding in the study. Now, Chris also measured the actual activity of these sensory fibers. This is showing traces from studies that Chris did. So this is a bipolar hook electrode around the renal nerves, and this signal is showing both efferent and afferent nerve activity. So you're measuring both activity to the kidney and leaving the kidney. But then if you make a cut, so you're measuring only the afferent activity and noise, that shows the signal here. And then you can cut both sides and get just the noise signal. So by subtracting out, Chris measured the afferent nerve activity in the kidney of these hypertensive animals. And this is a trace from his paper showing that. And basically what I want to point out here, you can quantify activity based on a voltage, an integrated voltage, or you can base it on a peak response to a stimulus, in this case, capsaicin, to elevate nerve activity. C and D are the take-home message of this. Here is afferent nerve activity in a normotensive rat. Here is afferent nerve activity in a DOCA hypertensive animal. So either way that you quantify it, you see this increase, and it's about 2.5 times higher than normal. So ablating the nerves decreases pressure. Measuring the activity of afferent nerves, it's elevated in this model. Now, I'm not going to spend a ton of time on this, but I do want to mention it because we're working on it. We have been for a while. The idea is there's some interaction of the nerves with this inflammation in the kidney. And so we measure at the end of the study a bunch of chemokines and cytokines in these animals. Let me pick out, so like for example, this is growth C. This should be the level in a normotensive rat. This is a DOCA salt hypertensive animal at the end of the protocol. If you denervate the kidney before inducing hypertension, not only is it normalized, it's actually below normal. And then this would be a sensory denervation. So there's two things I want you to pick out of this. One is cytokines are elevated in the kidney, which we think stimulate the sensory nerves, but also the inflammation in the kidney is dependent on innervation of the kidney. So there's been a lot in our field about how sympathetic nerves can attract immune cells can activate afferent nerves, and there's that vicious cycle and what we're trying to figure out. So Chris went on to do another study. The question came up, can we measure these cytokines in the urine as a biomarker for cytokines that may be activating the sensory nerves? So this is a study, and this one, either normotensive or not hypertensive animals that had intact renal nerves, or Chris did total renal denervation before. And again, we attenuate the hypertension by about 50%. But then Chris also collected urine and measured cytokines in the urine of these animals at, it looked like 3, 7, 14, and 21 days of the protocol. And what you can see for a variety of these, IL-1 beta, IL-2, IL-6, the cytokines in the urine mirror the blood pressure. That's number one. So here are the animals that had intact renal nerves. Denervating the kidney prevented the inflammation and the cytokines showing up in the urine. These are the renal cytokines at the end, and basically what I'm going to point out here is they're decreased by the denervation, similar to what we see in the urine itself. So the point here is the cytokines do show up in the urine. If they're cytokines that can be driving the afferent nerves, they could be a biomarker predicting efficacy of afferent renal denervation. Now, there's data in the literature now in humans indicating that this is possibly something that could be used clinically. This is a paper looking at an anti-inflammatory agent effect on urinary TNF alpha. These are subjects or patients who had psoriasis and rheumatoid arthritis and also had elevated blood pressure, and they're treated with mycophenolate, and that actually decreased urinary TNF alpha. There's evidence for IL-6 as a marker of acute kidney injury in children. Urinary cytokines in acute kidney injury during COVID, that came out in 2021. And more recently, looking at an automated analysis. So this is something we think has a lot of potential as a biomarker for what we want to look at. So we've gone around and around. Okay, there's lots of cytokines, and cytokines can activate nerves. This is from a review in the pain literature showing a sensory nerve terminal. And here's IL-1 beta, here's TNF alpha. These are just a couple that can activate sensory nerves. So we would talk about which cytokine should we look at, how do we go after this? Dan Bauman was a student, PhD student in the lab at the time, and he just said, I want to go after IL-1 beta. I think it's IL-1. We said, okay, go for it. So the idea of that is IL-1 beta or alpha can act on its receptor. That results in activation, upregulation of the TRPV1 channel. So more calcium does go into the nerve, which then activates the nerve. So it makes sense that that would be a pathway. And again, to remind you, we ablate these nerves by targeting that channel. So that seemed to make sense. The first thing, this came out last year, Dan had to show was the mouse looks like a rat in terms of doing total denervation or afferent denervation. That's what this slide is showing. So pretty much, again, this is the DOCA salt model, but it's in a mouse now. You can see the blood pressure goes up here. And if you do a total renal denervation before, like Chris did in the rats, that is right here. And just like in the rat, what Chris showed with afferent denervation only, you get the same effect on blood pressure. So again, it cuts it about in half. I'll mention quickly, because we'll come back to this a bit later, this is the amount of fluid the animals ingest. So these are normal animals. DOCA salt animals, they drink a lot of salt water. That's how they get their fluid intake or their salt intake. Denervating the kidney decreases that, and we'll come back to that a little bit later with Louise's work on salt appetite. This is showing, I won't go into the details, but by measuring globally sympathetic activity, this is the response to blocking all sympathetic activity with a ganglionic blocker. It's elevated in hypertension, but if you do the afferent or total denervation, you normalize that. Chris showed that in the rat as well. So afferent denervation decreases blood pressure in the mouse model. It also decreases saline intake, and it decreases the overall activity of the sympathetic nervous system. There's a lot of data in this paper, but I'll focus on just one aspect of it in terms of the cytokine aspect of it. Dan generated this model, let them get hypertensive, and then targeted the IL-1 receptor with anakinra, which is going to block that receptor to see what the blood pressure effect was in animals with and without afferent renal nerves, to see if we could find a common mechanism through IL-1 signaling and afferent nerves. So this is showing here, again, the DOCA salt model, blood pressure going from about 110 up to 150 here. If you give afferent renal denervation, or the antagonist. So this is the anakinra right here in the squares. You drop blood pressure here by blocking the IL-1 receptor. If you do only afferent denervation, it's the exact same response. And if you put afferent denervation and the antagonist together, it's the exact same response. So that fits with the hypothesis that blocking IL-1 is reducing blood pressure by an interaction of the afferent renal nerves. And I want to point out in E here, this is a really important part of this study. This is showing the blood pressure response to blocking the IL-1 receptor acutely in these hypertensive mice. So what you see here, when you give the IL-1, you drop blood pressure within 5 minutes and it stays down. That is a very rapid fall in blood pressure, which means either you're blocking a neurogenic mechanism or a vasodilator mechanism, for example. But this group here, these are animals that do not have afferent renal nerves. We performed the denervation. And what you see is the IL-1 antagonist won't lower blood pressure if the afferent nerves are not there. So this is all indirect, but when we put it all together, we do believe that this IL-1 signaling on the afferent renal nerves is a factor in driving the hypertension in this model. So we're really interested in translating this to humans. Could this be something that could be done in humans, taking what we've done in the rat and in the mouse? And the idea, could we use these urinary cytokines as a measure, a biomarker for the response to afferent denervation or even total denervation, either one. But we're really thinking about the afferent right now. So we moved into a sheep model, and this was driven by a bunch of people in the lab. But Arthur was an MD PhD student. He's now going back into medical school, so he's a PhD now. Lucy Volchanova in neuroscience, who's a collaborator with us on a lot of this, Elena Tokachova in biomedical engineering, and then John Carney runs a core facility here for doing a lot of large animal device development and surgical development. So the idea was, let's do the sheep model, and then let's take this catheter that's been developed by Ablative Solutions that can inject fluid into the wall of the renal artery and try capsaicin and see if we can do an afferent mediated denervation. So again, in humans, what's done is they inject alcohol, which is neurolytic, kills both afferent and efferent. But we thought, let's inject our capsaicin and do just a sensory denervation in the sheep model and see if that would work. So we just published this paper, which is the method for catheter-based afferent denervation using this catheter in the sheep. So these are images sensory in the sheep kidney. So here are sensory nerves, CGRP, in the left kidney, which was not treated. The same sheep, it's the right kidney, which was treated with capsaicin. And you can see very clearly the effect of this treatment. And you see very faint lines here, which maybe were the remnants of those sensory nerves. But that did abolish or ablate the sensory nerves in the sheep kidney. On the bottom is the marker for sympathetic nerves, so TH. So here is the non-treated kidney, but importantly, what you see here, the kidney that was treated, the sympathetic innervation is intact. But again, the sensory innervation is gone. So we feel this technique actually works very well. It's pretty straightforward to do in terms of putting the catheter in, injecting the capsaicin. So we wanted to see what it does to blood pressure. So we've developed this model in the sheep. The kidneys are intact. They get implanted with DOCA, and they get implanted with a transmitter that stores data in the transmitter and then downloads it to a receiver when they come nearby. And the beauty of this is we have a farm for the University of Minnesota, which is just across the border in Wisconsin, 45 minutes away, where we can house these animals and actually study them on the farm. So, for example, what we did is we put the antenna for the telemetry device right near where they come in to eat and drink every day. So all the data that's stored when they come in to eat and drink, it gets downloaded. So this is right across the road. Arthur dug a trench into this garage. There's the laptop sitting there, the computer collecting the data. And this is the first sheep we did. This is Dolly. And what you see here is we get a 24/7. This is showing blood pressure, but we also do ECG. And we can do it in freely roaming sheep, housed with all the other sheep, males and females together. So we feel this is a really powerful large animal model for hypertension. So the idea here then was, let's basically try to reproduce what we've done in rats and mice. So the sheep are instrumented with DOCA and the transmitter, allow them to develop hypertension for about a month, then do either total denervation or afferent denervation and follow them out. The beauty of the sheep model too, though, is that because it's a large animal model, we can get biopsies of both the ventricle. The idea was to look at ventricular inflammation and markers there, but more specifically the kidney, so that we can correlate that with what we pick up in the urine in terms of urinary cytokines and also markers in the blood. And we would do that before inducing the hypertension, at the time of treatment, and then at the end of the study. It takes a long time to do these studies. They're very expensive. We have not a lot of animals, and we're looking to get this funded. I'll leave it at that. But I'm going to show you preliminary data from this study in sheep. So we have an N of 2 in each group. And what you see here is, here's an increase in blood pressure with the docosalt protocol in an animal that is not treated in terms of any denervation. In red, at this point here, we perform a total renal denervation, and you see the blood pressure. This is, again, just an N of 2. And in blue is the afferent denervation. And you can see blood pressure is down, but it's not as much as a total denervation. So you might say, unlike the rat and the mouse, this does not repeat that, and that we got the same effect on blood pressure. But this is where the biomarker comes in. We collected urine and analyzed for cytokines right before treatment to see if we could predict response to the treatment. I'm going to show you one of the biomarkers. We did a bunch of them. I'll go through this one and mention a couple others. This is IL-1 alpha right before the procedure. Now, when you do total renal denervation, you are taking out afferent nerves. And when you do afferent denervation, you're taking out afferent nerves. So I've plotted all 4 of these sheep because they all do get an afferent renal denervation. And the idea is the inflammatory cytokine is driving those nerves. So the level in the urine will predict the response to denervation. And in fact, this is a really tight correlation here. So this sheep had very little IL-1 in the urine, meaning inflammation was low according to this biomarker, and very little response to blood pressure. This sheep had the most IL-1 and had the biggest drop in blood pressure. We saw pretty much a similar pattern for TNF alpha and IL-6. Okay, but again, very low numbers, but this is the basic idea. So that's where that's at right now. We're working on continuing those studies. And I want to switch over to this idea of interoception for a minute that Sue had talked about, because this is something that's become more and more, people become more and more aware about. And it relates to everything I'm talking about with the kidney, but also within the Spark program. Certainly not a new idea. Pavlov was the one who initially came up with this idea. When we talk about Pavlovian conditioning, so for example, a dog hearing a bell and salivating or whatever, that's an external cue. But he also talked about changes in the body, in the milieu interior, right? That could cause a conditioned stimulus. And he referred to this as interoceptive conditioning. So some signal in the body that results in a perception that alters autonomic output or neural output. And then Sherrington, of course, another famous neuroscientist who also got the Nobel Prize, he came up with the idea of the interoceptor and interoceptive. This is now back into vogue, I would say, and rapidly emerging. This is a really nice white paper that was published in 2016. I've highlighted Larry Schramm here, my postdoc mentor was a part of this group. This is showing publications that either refer to interoception in one way or the other, and you see this huge inflection point around 2012. And the concept is being able to sense signals coming from different organs that are then processed and result in output pathways of autonomic activity and other things. Now, there was a Keystone conference just this past summer that a few of us went to from here that was sold out. It was all about interoception. It was a really excellent conference. And so this is really bringing together sensory physiology, autonomic physiology in a way that I think is very exciting. So what does this have to do with interoception that I'm talking about? And why are we thinking about it? Why does it matter? So again, interoception is the perception of sensations from inside the body, includes the perception of physical sensations related to internal organ function, heartbeat and respiration, satiety, as well as autonomic nervous system activity related to emotions. And emotions is a key word there. And we're talking about information that we've been working on coming from the kidney and going to the brain. Now, this is a recent review that talks about interoception, and this gets into what we haven't typically thought about, and that is in terms of the mental state or emotional well-being. And the idea in this review is that similar to signaling of other physiological processes, central communication of peripheral inflammation in the organs, dependent on interoceptive visceral afferents traveling either in the vagus nerve or other autonomic nerves. So for example, the ones I'm talking about from the kidney. These afferents express cytokine binding sites, which has been shown. So the concept then is when you have prolonged inflammation and immune activation, this can lead to psychiatric disorders, depression, PTSD, autism, those kinds of things. So this is now connecting up even further up from autonomic pathways up into behavioral pathways. There's one case report on renal denervation that's shown here. And what they did was basically it's a survey, I believe, looking at quality of life, anxiety, and depression before and after renal denervation. And what they reported in this particular participant, that following renal denervation, there was reduced anxiety and depression, intensity of headache, improved QOL score, and stress tolerance. So this is, not tight by any means, but it indicates interrupting these pathways from the kidney may also influence things such as depression, not just sympathetic nerve activity. So we've become very interested in this. These are two review articles led by Louise Evans. This one in Autonomic Neuroscience, which you just heard about. We're great to publish in that journal. And then more recently in Nature Reviews Nephrology. And so you can go to there for more details for sensory input from the kidney up to the brain, not only autonomic areas, but some of these interoceptive circuits as well. So there'll be more detail there for that. Now, realizing that and thinking about that, then we ask this question, and we've been asking this question for a long time. Where are these nerves in the kidney and what are they actually sensing? What is the role of them physiologically, normally day in and day out? And then what about pathology like hypertension? So there's a lot to do here, obviously. So I want to talk about this one first. So this is a study, Sue mentioned it at the very beginning. It's now in the database. Um, This was funded by Spark. So Lucy Volchanova is my colleague here in neuroscience, and then Roman, who's on the call. This is his PhD project here in the graduate program in neuroscience. And Roman is now also working with us on this Reveal project as well. So now I like to use this image because this is a kidney, it's not a brain, even though you have a cortex up here and you have a medulla down here. Is a cross section of a kidney, and the blue staining are sensory fibers. And classically, using older techniques, you would see a lot of this in the pelvis, not so much in the cortex. And so a lot of the thinking about renal afferents has been pelvic afferents. But what you see here when you look at the kidney is, hopefully, there we go. All of these green dots here are glomeruli. That's the functional unit of the kidney in terms of filtering plasma and making urine. So this is from a paper from another group showing intravital image of the glomerulus in a rat. So here's the glomerulus right here. Here's the afferent arterial end of the glomerulus, and you see the pulse of the glomerulus, which is every heartbeat. And what I want you to notice is that that is moving. It's a physical change with pressure, right? So the diameter of the glomerulus is changing. So Roman then started to implement more state-of-the-art imaging methods to look at these sensory nerves using cubic tissue clearing and other methods and using different genetic strains in the mouse. And this is all in the data set in the paper that I showed you or I referenced. And what Roman found, so I have a few of these beautiful images that Roman generated. This is the magenta here is a sensory nerve. The green is the glomerulus. And you can see this sensory nerve coming down and kind of traveling over the glomerulus here and here. You see other images here. You see this 3D image here, right? So Roman went through and scanned a lot of kidneys for these sensory fibers and found many examples of this close approximation of these sensory fibers around the glomerulus, which had never been seen before. Now, for those of you who don't think about the kidney, Bowman's capsule is epithelial cells that surround this capillary tuft that it's tucked inside of. And what it seems like when we look at this, the nerves never go inside of the glomerulus. They hug around Bowman's capsule or they're on the outside. And you see these varicosities here. So we think they're hugging the capsule and responding to that change in pressure like a baroreceptor would. That would be the idea. And this image is showing Roman found several examples where several glomeruli were all in contact with one sensory fiber that would branch off to those glomeruli, right? So we would call these like a module or a unit that received that sensory information. So we haven't figured out what they do yet. The hypothesis we have right now is they do sense the distension or the pressure of the glomerulus. So if you have an increased pressure and you distend, you activate these. For example, piezo2 channels may be involved. We don't know yet. When you activate those sensory nerves, that goes up to the spinal cord and then results in a situation where you activate the nerves the sympathetic nerves to the afferent arteriole, which is going to constrict it and normalize the pressure in the glomerulus. So we do think that there is an ongoing interoceptive kind of loop there that is regulating glomerular pressure. Now, if you add to that, you have inflammation in the glomerulus, you're going to drive that into hyperdrive, right? So that would be the inflammatory part. So we have to test this hypothesis yet. So I'm gonna, with the few minutes I have left here, I'm gonna go through some examples of how these afferents are regulating things we haven't typically thought about, but we're learning that they do. So Mariana is a research scientist in the group that works with this model of hypertension where you put a stenosis, you create a stenosis on the renal artery of one kidney, it reduces the flow by about 50%, and you recover the animals, and they develop high blood pressure. So one kidney is saying or seeing that it has a low blood pressure. And typically, hypertension is thought to be due to activation of the renin-angiotensin system. And there's a lot of studies that actually came out of Brazil where Mariana trained, and others that suggest that's what it does. But we think it's actually a different mechanism. This is very much like what I showed you with the DOCA salt model, what I talked about with Chris and Dan and in the sheep. Here's the hypertension in animals where we cause a renal artery stenosis. If we do either just afferent or total denervation, you cut it in half. Again, sensory denervation reduces the hypertension by 50%. The bottom here is the sympathetic nervous system activity that we measured. It's activated in this model. If you get rid of the sensory nerves, it's normalized. This is something that we didn't predict. When you clip that kidney, their water intake goes from drinking 40 mils a day almost up by 3 times. They drink water like crazy. And these are those animals there. But if you get rid of the afferent nerves or denervate the kidney completely, that water intake is not there. Urine output follows the same as it would with fluid. The bottom, the important thing here, this is a marker. This is urinary copeptin. This is a marker for vasopressin that comes from the pituitary gland, and it causes water retention. It's a hormone that's very important to water balance. That gets activated like crazy when you clip the kidney, but it doesn't at all if you do an afferent denervation. So we interpret this to say when one kidney doesn't have enough blood flow, it sends signals to activate the sympathetic nervous system, drink water, and release a water retaining hormone. So this is totally novel in terms of thinking about signals from the kidney that would drive this model of hypertension. Okay, I'm getting close to the end here. I want to mention this is very exciting work that is coming out of Louise Evans' lab. Again, Mariana was involved with this, and so was Rowan, who's a PhD student here. They have just published this recently showing that salt appetite, I told you aldosterone or DOCA-treated animals drink a lot of salt. Well, Louise tested the idea the signal for that is actually coming up from the kidney through these sensory renal nerves. This is the amount of salt that these animals drink when you give them this DOCA, and they drink a lot of it over time. But if you take out only the afferent nerves, which are the boxes here, they do not drink more salt. Total denervation does the same. So that drive to drink salt goes away if you get rid of the sensory input from the kidney. If you look at water, it doesn't do that for water intake, which says this is very specific to sodium. And Louise is doing a lot of work on this now to get at the mechanism. Basically, what she's thinking is when aldosterone gets released because you need sodium to retain it at the kidney, right? The idea is when aldosterone acts in the kidney, and we think it's through activation of these channels in the kidney itself, there are mechanisms that activate the sensory nerves and say, eat more salt. So the hormone goes to the kidney to retain sodium, and also signals from the kidney to the brain say, eat sodium. And the idea is this could be a target for treating people who have too much salt or drink too much salt in their diet or have too much salt in their diet. Okay, so we're doing a lot of different translational work from the mouse to the rat to sheep. We've been a clinical trial site for both ablative solutions and now Verve Medical, which is a totally different renal denervation company, trying to put this all together. So both within the division and then within our Neuromodulation Consortium, we're trying to put this together. So the take-home message I'll just say here is, the kidney for targeting for hypertension, that made a lot of sense based on the role of the kidney in hypertension, the nerves to the kidney in hypertension. You can get a catheter in there easy. But this story I'm telling, I'm sure applies to every single organ in the body, right? Sensory nerves from the organ to the brain are absolutely essential to regulation of their function in the autonomic nervous system. Inflammation is going to activate those chronically, which is going to result in a variety of diseases. And therefore, doing an organ-based neuromodulation, I would say rather than ablation, is the way to go. So then just to plug for our consortium, this is really based here at the University of Minnesota and the Mayo Clinic, our partners there as well, where we're taking that approach to do neuromodulation of various organs, large animal models, small animal models, based on that basic initiative. I put a slide together that has a lot of the people I've talked about and other people involved. I think there's even more. And we have a huge team here working on this. So I just want to say I'm the talking head for the group. I get to talk about what everybody's doing, but this has really been a massive effort by lots of people here at the University of Minnesota. Okay, I know that might have been fast and furious, but that's basically the approach we've had. We've been focused on the kidney, but like I said, I think a lot of people, certainly in this audience, are well aware of the fact Spark is targeting other organs as well, both in afferent and efferent. So I'm happy to take any questions at this point related to this or the reveal or whatever. So thank you.
Oh, thank you so much, John. That was really tremendous. That was a lot of data, a lot of coverage of just all the complexity that is bringing things to and from the kidney in terms of
Right.
information. I really thought that was really fabulous. I invite everybody to pop your questions into the Q&A panel. You'll see that a seminar survey just popped up. If you'd like to present or offer a topic for a new seminar in the next series, please let us know. We'd love that. But John, I'm going to get you started with the first question that actually was submitted, and the question comes as how do you separate out interoception from the idea of neuroplastic changes in response to changes in the afferent input?
I don't know if you do when we talk about, for example, I mean, there's a lot of work on VNS and other things for addiction, right? And so those could go together. And actually, the way I respond to that question related to the renal nerve stuff we've been doing, when you do this renal denervation in patients, their blood pressure stays down for a really long time, years and years, it seems. The question that's come up is why is that? Because there's evidence that maybe the nerves will grow back. One explanation is you've interrupted a circuit that is
Simple.
rewired, reverberating, right? In hypertension, that you've interrupted that long enough to reverse that, and then it doesn't come back. And I don't know, I'm happy to come back if that doesn't get to that question. But, and interoception, sensory physiology, defining how those go together and what they mean is actually, there's a lot of discussion around that. So I'm not sure if that answers the question, but hopefully.
Okay, well, hopefully they'll respond back if they want to raise up another point. So, so the kidneys are bilateral, right? It's not like the heart where there's only one. And so do you envision a strategy that would target both kidneys symmetrically, or some other mechanism
You've
in
got to
an
get
ideal
both of them.
scenario?
I mean, when you're doing these denervation procedures in patients, you target both kidneys. So I do think if you're going to do neuromodulation, it would have to be both kidneys for sure, right? So yeah, you'd have to go after both. Yeah.
Okay, and when you spare the sympathetic nerves when you do the afferent denervation only, what are you retaining? So how does what is that efferent pathway look like without the afferent coming back?
Well, I mean, people ask the question, why do we need to bother with doing this sensory-specific denervation? That's one way to answer the question, and that is the sympathetic nerves are there for regulating pressure during periods of shock, like hemorrhage shock, septic shock, those kinds of things. So targeting only the afferents means that you lower blood pressure for hypertension, but you don't interrupt with those normal physiological mechanisms. Now, whether those pathways are altered by afferent denervation, I don't think anyone's really looked at yet. Yeah,
So that sounds like a good open question.
sure. Yeah, yeah, yeah.
So, uh, um, all right. So you touched on the vagus nerve, and obviously VNS stimulation, but that's not the main contributor of innervation to the kidney. Is that right? And
So
so,
there's controversy around that. The kidney has thought not to be innervated by the vagus nerve or parasympathetic. There's evidence, and we've been looking at it with our anatomy studies, whether there's sensory that goes up through the vagus into the nodose ganglion, and I'm going to say there might be.
Mhm.
So that's left to be actually determined. But the classical view is the parasympathetic has nothing to do with the kidney.
Right, but the vagus is a mixed nerve anyway, so it really could have um, alternate fibers traversing through.
So when you say that, when you say mixed nerve, like sympathetic fibers in the vagus, is that what you're referring to?
And sensory,
Well,
right?
sensory, yeah, no. So, but I am talking about sensory nerves that would go from the kidney up, sensory nerves of the vagus to the nodose and in. There's evidence that those might be there, but
Mhm.
we're not sure.
Okay, and so we've got a question about the importance of the splanchnic nerves then.
Mm.
What do you think the role of these guys are in your context?
It's very important. So I've been talking about this recently. So I think I saw Greg Fink. Yeah, he's still on here. So Greg really kind of revived and got going the idea of innervation of the splanchnic circulation in hypertension, not the kidney, but the splanchnic circulation. We collaborated with him on some of those studies, so that is very important actually. And we've done studies. Greg's done studies. We've collaborated. If you do splanchnic denervation, you can lower blood pressure just like renal denervation. If you do them together, they're additive. So I will make the point here, the kidney is not the only target for hypertension. It's one target. It's not the only one. And the splanchnic circulation is definitely a good one.
Okay, that sounds great. Victor Pikoff has a question for you.
Mhm.
He'd like to know, based on the data that you presented showing an elevation of pro-inflammatory cytokines in urine
Mhm.
in those autoimmune diseases that were presented, so
Yep.
psoriasis and RA, it it's it seems unlikely that the urinary cytokine levels provide a specific biomarker of renal inflammation. Rather, they are likely non-specific biomarkers of inflammation anywhere in the body. So, I mean, the kidney does collect
Yeah, that
from.
comes up. We've measured these in the plasma and we don't see much.
Mhm.
So for example, IL-1, we don't see it elevated in our models. I'm not saying that can't be true. It can be. And so this whole issue, I mean, there's a bunch of cytokines that show up in the urine, and some of them may not have anything to do with renal inflammation or activating the efferent nerves. That's been the thing we're trying to figure out. So I agree, we're not there yet, but it's complicated.
Well, if it were simple, it'd already be sorted, right? We have a question from Samuel Trevino, and Samuel would like to know if you think that the nervous system controls hydroelectric homeostasis independently of RAAS, so RAAS.
So does the nervous system regulate hydromineral balance? I'm guessing that is independent of the renin-angiotensin system. To the sensory nerves from the kidney, regulating both intake of sodium and water. That would
Mhm.
be one way in which those are going to contribute to sodium and water homeostasis, right? We were really surprised in this model of the two kidney, one clip of the rat, which has classically been thought to be driven by the renin-angiotensin system, that we can reverse a lot of the things that drive that just by getting rid of the sensory nerves. So I do think there is an important role for the sensory the afferent nerves from the kidney in that, in terms of sodium and water intake, if that's answering the question.
Okay, I think that sounds good. I hope that addresses Samuel's question. Okay, I think if you have got time, I've got a couple more questions,
Sure.
but this one piggybacks off of Victor's.
Mhm.
So if inflammation is the signal triggering hypertension, can you
Mhm.
lower the bodily inflammation? So like, hey, let's just reduce
Mhm.
the rest of the inflammation in the body and block that signal transmitting the inflammation signal.
Yeah, there have been clinical trials done on anti-inflammatories, and none of them have really worked for
Mhm.
hypertension. So that comes up. Um, and I would say, I think there is a certain level of pressure in the kidney it has to get to before you cause the inflammation to start. So I'm not saying it's all inflammation, it's not all nerves. I mean, none of these interventions could we prevent hypertension. We can lower blood pressure. There are other mechanisms that are happening for sure. But so far, reducing systemic or global inflammation hasn't been seen to work. We've looked at giving some anti-inflammatory drugs. Well, the one blocking IL-1 receptor, for example,
Mhm.
in mice seemed to work really well. And that did seem to be related to the mechanism I was talking about. But I think we still need to follow up on that for sure.
So So you started off with the brain kidney axis, and then you gave us all sorts of great information about why the kidney brain axis is really where a lot of your research has been focused. The last question is related to more of a global bridging the body and the brain type
Mhm.
of scenario, and the question is a little bit off topic according to the attendee, but I think it's right on topic,
Let's
which
go.
is that they came across two articles suggesting that Parkinson's disease may start forming alpha-synuclein being
Mm.
transported from the kidney to the brain. Do you have any knowledge on that
I saw
topic?
that paper. I saw that paper. It's
Yeah,
really interesting that somehow transport of that from the kidney to the brain was involved in Parkinson's. That just came out recently.
yeah.
I can't remember. It was in Nature or somewhere. So I think those of us who study the autonomic nervous system in whatever capacity, it's always been challenging. It's hard to measure. You have to be an organ-based physiologist and a neuroscientist and do all the things. It's going to be even more challenging to study the whole interoception and sensory stuff. But I think that's where the action is myself. I really do.
Mhm.
So in terms of interoception and sparc and what we're doing here, I think we should all be targeting that, no pun intended, to figure that out.
Yeah. Okay. I couldn't agree more. I think that would just be the right way to go. Keep all this data all together, and let's all work on um, uncovering new dimensions and treatments together.
Yeah, I mean, this is the in vogue topic now too, in terms of deep breathing, yoga, all these things where you modulate your autonomic nervous system. It's through manipulating interoceptive pathways, listening to your breath, feeling your breath, your heartbeat, all of those things, right?
Yeah,
So
all
there's
that big
something
old
to that.
tongue.
Hmm.
Yeah. All right. Well, on that note, everybody, take a moment after this seminar, stand up, do a couple deep breaths before you start your next action. I want to thank John very much for your wonderful presentation. Thank you to everybody who attended, and we will be making this video available on YouTube so you can share with your friends.
Thanks, everybody. Contact me with other questions. I enjoyed it.